to left, in systole from left to right. And the interaction depends on the degree of loading of the right ventricle, especially on the venous return effects, and secondary on the afterload effects. Thank you very much.
Are there any questions for Rico?
Thank you very much. We recently finished a study in 20 cardiac surgery patients in which we put in a pleural balloon and a pericardial balloon at the end of the operation, closed the pericardium, and then they got back to the ICU. And what we actually found is that the pressure increase in the pericardium was only 25% of the interthoracic, of the alveolar pressure. So it's actually very tiny. And if we calculated that, then you must say that the effect on the left ventricle, the decrease in afterload for the left ventricle, must be almost negligible. It's almost nothing, I would say. It would be 2.5 centimeter water, 2.5 millimeter of mercury, against a stiff left or thick left ventricle. So what do you think about it?
You mean the decrease in afterload for the left ventricle, or the increase for the right ventricle?
No, the decrease in afterload for the left ventricle must be minimal.
I mean, it depends, once again, it depends, of course, on the circumstances, because after cardiac surgery, your compliance in the mediastinum is altered, obviously. Yes. And that's been also shown in, if you go to the animal labs, if you take open-chested or closed-chested animals, the effects are vastly different. The only thing I can say indirectly is that if you take a patient with an intra-aortic balloon pump and you switch that off and you compensate for that by increasing intrathoracic pressures, you can actually have very similar hemodynamic effects. But I take your point, and of course it's a very important point to consider in patients, whether the local conditions are normal or altered. That's also the same thing is for a very stiff lung in terms of alveolar pressures and their impact on the pulmonary circulation itself, and also on the venous return.
Thank you. Other questions? Crystal?
The stroke of the diaphragm will also generate a significant push or recruit volume from the abdominal circulation. How do you manage? How do you see that? Is that the effect that you see when you compare the pressure support compared to the NAVA?
Well, I think once again the direct impact of the diaphragm, I think you can't separate them from the pressure effects of the diaphragmatic motion on the intrapleural pressure. So I don't think there is much of a direct effect of the diaphragmatic contractility, rather than its impact on the change in the volume, which creates the pressure swing intrapleurally. Furthermore, of course, the effects on the venous return depend also on the overall filling of the capacitance vessels, as well as on their vascular tone. Because as we know, if we have a well-filled capacitance vessels, we have a large stressed volume in the circulation which can be rapidly recruited. The effects are completely different if the stressed volume is low. I mean, the stressed volume normally in a normal volemic patients is about 1,200 mLs. If a patient is slightly hypovolemic, you can have a much slower stress volume in the circulation, and then the possibilities to recruit volume are, of course, completely different.